Now that we have an understanding of normal waveform components, let's move our discussion to identifying clinical situations that can be detected by evaluating ventilator graphics. We will start our discussion with flow time curves. Expiratory flow depends on the resistance of the ventilation system, the endotracheal tube, and the physical properties of the airways and lungs. Zero flow at the end of exhalation indicates that the patient has finished breathing out before the next breath is delivered. Shown in red is the expiratory portion of the flow time curve. Notice how the expiratory flow curve returns to the baseline between each breath. If the transition from exhalation, shown in red, to inspiration, shown in blue, occurs without expiratory flow returning to zero, auto-PEEP is present. Auto-PEEP is usually caused by insufficient expiratory time as a result of an inspiratory time that is too long, increased expiratory resistance, and early collapse of alveoli structures. The farther the transition from inspiration to exhalation is below the baseline, the greater the air trapping. The values on the vertical scale represent flow, not pressure. The clinician can only identify that auto-PEEP is present, not measure how much auto-PEEP is present. On the Esprit ventilator, use the expiratory hold key to measure auto-PEEP. How does auto-PEEP affect the patient's work of breathing? Let's take a look. When auto-PEEP is present, the patient has to pull pressure through the auto-PEEP to trigger a breath. For example, if the patient has 7 centimeters of water of auto-PEEP and the pressure sensitivity is set at 2 centimeters of water, the patient would have to pull a negative 9 centimeters of water in order to trigger a breath. In flow triggering, flow is not initiated until the patient pulls through the auto-PEEP, creates a negative pressure in the lungs, and meets the flow trigger sensitivity criteria. Undetected, auto-PEEP can cause increased work of breathing for the patient. In the graphic above, the arrows indicate a missed patient effort. On the flow curve on the left, expiratory flow is blunted and the expiratory phase is drawn out. In comparison, the flow curve on the right shows a higher expiratory flow rate and a more common decreased expiratory time, denoting lower expiratory resistance. This decrease in expiratory resistance is often observed after the patient receives a bronchodilator treatment. Monitoring the duration of the bronchodilator effect can help determine the frequency and effectiveness of bronchodilator therapy. The same decrease in resistance may also be observed when a clogged expiratory filter or an HME full of secretions is replaced by a new filter. Observing the flow time curve provides insight to setting inspiratory time in pressure-controlled ventilation. For example, the physician orders PCV with a target tidal volume of 500 milliliters. Pressure-controlled ventilation is initiated with a driving pressure of 20 centimeters of water and an inspiratory time of 0.7 seconds, resulting in a delivered tidal volume of 450 cc's. What setting would you change to increase tidal volume? If you answered increase the driving pressure, that is one way of increasing tidal volume. Before increasing driving pressure to obtain additional tidal volume, consider increasing the inspiratory time. As illustrated here, inspiratory flow does not return to zero before cycling into exhalation. This can result in potential lost tidal volume as indicated by the green arrow. Increasing inspiratory time allows the flow to return to baseline and enhance delivered tidal volume without increasing driving pressure. By increasing inspiratory time to 1.2 seconds, inspiratory flow returns to baseline and the 500 milliliter tidal volume is achieved. This section reviews the clinical situations that can be identified by observing pressure time curves. The pressure time curve can be utilized to improve patient-to-ventilator synchrony. If the patient has explosive inspiratory flow demands in volume control ventilation, greater than the peak flow setting on the ventilator, the inspiratory phase of the pressure curve will be concave with a negative deflection point. This is often referred to as flow starvation. Either increasing the peak flow setting or switching the patient to pressure control ventilation can improve patient comfort and help to meet their inspiratory flow demands. On the Esprit critical care ventilator with the flow track option in volume control ventilation, if the set peak flow or tidal volume does not meet patient demand, the flow track system will make additional flow available to satisfy the patient's need. Flow track allows for free breathing and unrestricted access to additional flow or volume within a standard volume-controlled breath, all without increasing driving pressure. The flow track option enhances patient-to-ventilator synchrony. If the rise to pressure is too fast, a pressure overshoot can occur. Although the small pressure overshoot is not transmitted to the lungs, it can be uncomfortable for the patient. In pressure support ventilation, the overshoot can end the inspiration prematurely, resulting in decreased tidal volume. This pressure waveform shows a pressure overshoot associated with a 0.1 second rise time in pressure control ventilation. This can be caused by small endotracheal tubes and high resistance to inspired flow. By changing the rise time to 0.3 seconds, initial flow output is decreased, causing a more gradual rise in inspiratory pressure and eliminating the overshoot. Now let's turn our attention to clinical scenarios that we can detect by observing volume time curves. What is happening here? The volume time curve is a good place to observe the effect that a leak or early air trapping has on exhaled tidal volume. The difference represented by the arrow in the volume time curve is the lost exhaled volume. When exhalation, shown in red here, drops below the baseline, it usually indicates forced or active exhalation. Also, if the patient has auto-PEEP due to an increased respiratory rate, then relaxes for a few breaths, more exhaled than inspired volume may be seen. There are a number of clinical situations that can be detected by observing the pressure-volume loop. In normal compliance, the slope of the pressure-volume loop is approximately a 45-degree angle to the horizontal axis. As illustrated on this slide, in patients with decreased compliance in volume ventilation, the slope of the loop will shift right toward the horizontal axis, indicating a higher pressure required to deliver tidal volume. The difference between the green arrow and the blue arrow represents a change in compliance, as indicated by an increase in pressure with little corresponding increase in tidal volume. In patients with increased compliance, for example emphysema, the loop will shift left toward the vertical axis. The solid blue line on the graph depicts increased airway resistance. This is indicated by the bowing of the loop as the ventilator, in volume control ventilation, applies more pressure to move the same volume. This is a spontaneous breath. The black arrow indicates imposed patient work of breathing. Inspiratory effort to the left of the vertical axis translates into an increased inspiratory workload for the patient. When the graphic is frozen, the amount of imposed patient work is estimated by the Esprit ventilator and is displayed as inspiratory area. This is commonly reduced by instituting flow triggering or increasing pressure support. When a graphic is frozen, the amount of imposed work is estimated by the Esprit critical care ventilator and displayed as inspiratory area. This imposed work is commonly reduced by instituting flow triggering or increasing the pressure support level. A significant number above 0 indicates the patient is incurring work to initiate and sustain the breath. What would cause the PV loop to flatten as we see here? The flat part on the top of the red curve just after inspiration and at the beginning of exhalation is due to circuit compression. Often this is confused with lung overdistension. The higher the delivery pressure, the greater the compression. Overdistension is caused by high local transpulmonary pressures and occurs when the lung's volume capacity is reached. On this slide, pressure increases with little to no increase in tidal volume. Peak inspiratory pressure is line A and line B is delivered tidal volume. Overdistension can be caused by too much PEEP and pressure or too much PEEP and tidal volume. The decrease in compliance causes the slope to flatten, creating a beak-like appearance at the end of inspiration. The point at which this line begins to flatten and form the beak is sometimes referred to as the upper inflection point. Besides causing volutrauma or barotrauma, overdistension of the lungs can decrease venous return and cardiac output. Decreasing PEEP, set tidal volume, or set driving pressure can reduce or correct the overdistension. Most ventilator graphics give the clinician an option to freeze or save a waveform. This provides an opportunity to analyze the waveform more closely. The clinician would first freeze the graphics display and then use the arrows to move the cursor to the appropriate point. The value coinciding with the cursor position is displayed in the window. The clinician could also save a waveform and later superimpose a new waveform in order to monitor responses to changes in parameters or bronchodilator therapy. Next, we will discuss clinical scenarios observed on flow volume loops. This is a normal flow volume loop for a VCV breath. Inspiration is in blue and exhalation is in red. An abnormal flow volume loop is shown in purple. Note the decreased peak expiratory flow rate and the scooped-out pattern associated with increased expiratory resistance. Clinicians utilize this waveform to evaluate the effectiveness of bronchodilator therapy. As the medium and small airways open, the peak expiratory flow rate will increase and the expiratory flow pattern will return to normal, depicted by the broken red line here. Leaks are easily detected with the flow volume loop because expiratory flow does not return to baseline as depicted by the purple curve. The baseline of the graph is equivalent to the patient's functional residual capacity. The amount of lost exhaled tidal volume is indicated by the green arrow. What could cause a scalloped or sawtooth tracing on the expiratory portion of the flow volume loop? This is often seen with a partial obstruction in the airway or circuit. Examples include secretions in the upper airways and water in the dependent loop of the ventilator circuit. The Esprit ventilator has the ability to trend patient data, ventilator settings, respiratory mechanics data, and NICO data for up to 72 hours. Often information viewed over time as a trend is easier to interpret than values on a ventilator flow sheet. Additionally, trending ventilator settings and patient data together present a clear picture of cause and effect. The following examples highlight just a few of the advantages of the trending option on the Esprit ventilator. This slide illustrates three trended variables: static compliance, set PEEP, and exhaled tidal volume. While on a PEEP of 10 centimeters of water, the patient's exhaled volume was 500 milliliters and static compliance was around 40 centimeters of water. After PEEP was increased to 15 centimeters of water, static compliance decreased to 30 centimeters of water and the volume dropped to 350 milliliters. In pressure control ventilation, when the lungs are overdistended, lung compliance and tidal volume decrease. Note that when PEEP is set back to 10 centimeters of water, static compliance and tidal volumes increase. Trending PEEP, static and dynamic compliance can be a useful tool to help establish optimal PEEP. This screen displays a patient's spontaneous rate, set pressure support, and TIT tote. These parameters can be useful when weaning a patient from ventilator support. Notice as the pressure support ventilation was decreased from 10 centimeters of water to 5 centimeters of water, the patient begins to fatigue, respiratory rate, and TIT tote significantly increased. When the pressure support was increased back to 10 centimeters of water, the patient's work of breathing decreased. From the trended data shown here, the clinician can evaluate the effect a leak has on the patient's respiratory rate and tidal volume. With over 34 parameters to trend, the caregiver can gain valuable information on the patient's response to various setting changes, monitor changes in the work of breathing, changes in resistance and compliance over time, and evaluate the success of weaning trials. Ventilator waveforms and patient trending can guide the clinician in identifying problems and making appropriate clinical adjustments to improve patient-to-ventilator synchrony. Indeed, graphics are worth 1,000 words. To obtain 1 continuing education contact hour for this course, proceed to the post-test and course evaluation.